I'm Dr. Saqif Shahriar, working in ICBD. I shall be talking on different modalities for treating calcified lesions. In daily day-to-day practice, we are dealing with about 5 to 10% of the calcified lesions, and we have to face different difficulties in our scenarios because we have not all the tools available in all the centers. And this is the story of 74 years old gentleman, relative of a doctor, hypertensive, diabetic, non-smoker, patient hailing from Dhaka, NICBD CCU, complex of central chest pain, hemoglobin stable, and his troponin diagnosis non-STMI, STT changes, and echo revealed LV systolic dysfunction mild. And he was underwent CAG in another center, and which revealed TVD. And we recheck the angiogram and the radial route. This is the right side. We showed heavily calcified RCA, and from proximal to distal part look like almost like a stented vessels, term like calcium. And also the left side, it is showed proximal LAD significant disease, and also the downstream disease, and LCS has some borderline disease also. And syntax score was calculated. It is the intermediate lesions. We counsel the patient party that is benefits, and but the patient plan to go for PCI. And first we go for IVAS, evaluation of this patient to see the extension of the calcium, the vessel size, distribution of the calcium, and which modalities we should use to crack the calciums of these patients. And this is the IVAS pullback of the RCA. We showed it is a calcified in distal, also mid part of the RCA also. Most of the there are some calcium nodules and more than 270 dark calcium, especially in the proximal and the mid part of the RCA. And we also did OCT of this patient, because in our center OCT is available, and we are in the initial stage of imaging modalities of OCT. We are learning. So in the same patients we do in our center, there are some deeper calciums and also some calcium nodules, and more than 270 are calcium also. In this, this is the OCT view of this patient in the mid RCA, and in the mid RCA cross section which shows more than 270-degree calcium. Calcium thickness is long, and more than 5 millimeter of calcium also. And is the proximal RCA, there are some calcium nodules. And this is the algorithm or rhythm, and according to the OCT criteria, we if there is calcium eccentric calcium, we can go for NC balloon, cutting balloon, or scoring balloons. And the concentric calcium more than 270 degree are more than 5 millimeter thickness or 5 millimeter length, then we can go for rotational atherectomy or orbital atherectomy or lithotripsy also. And in nodular calcium, so we can go for rotational atherectomy, orbital atherectomy, or lithotripsy. And in our cases, we can see there are some calcium nodule, eccentric calciums, nodular calciums, and more than 270 are calciums. So we go for rota ablation, 1.5 bar from the proximal to mid part, then pre-dilated the lesion 2 into 12 millimeter, then 2.5 and 3 millimeter NC balloon in the proximal part, and use of scoring balloons also, and stented the vessels, and post-dilation was done. And post-dilation was done by 3.5 NC balloon, 3.5 into 12 millimeter NC balloon. And this is the final result. And good. And this is the post-stenting OCT run, which shows that there is no edge dissection, and MSA was good, optimal, more than 80% expected, and there is no under expansion or malapposition of the stents, and the well apposition of the stars. And the 3D OCT view also shows there is no red or yellow marks for under expansion of the stents. And on the left side, first we took a NC balloon at high pressure, but you can see there is a dog bone effect in the proximal part. So in this case, we use the intravascular lithotripsy balloon, IVL balloons. And in the most right panel, you can see after using the IVL balloon, the dog bone effect has been gone. So, and in the proximal part of the LCX, there is a borderline lesion. We only go for plain balloon angioplasty, and then we go for IVAS run into the LAD, which shows significant calcium, more than some part is 360 calcium. So after adequate pre-dilation and after the IVL, we can put the stent from LM to LAD crossover stenting, and post-dilation does, and port was done with the 1:1 balloon. And this is the final result with good appreciable result. So my take-home message: the burden of large calcification plaque adds an extra level of clinical and technical complexity of PCI, and it has become more evident that combination of intravascular imaging and novel therapeutic technique representing the treatment of high calcium level, and intravascular imaging can provide degree of calcification, its location, distribution, concentricity, eccentricity, thickness, and longitudinal extension. Based on the information from the image, selection of the technology to lesion preparation of high calcium concentration is selected, and high degree of severe calcific lesion require a more aggressive lesion preparation with rotational atherectomy, IVL, or orbital atherectomy. Thank you, everyone. Thank you for your patient hearing, and I must acknowledge my professor and the team of NICBD. Thank you.